All right, we're live streaming, so we're ready to go whenever you are.
Okay. And is Christina here yet? No. I don't know if she's sitting in on the session.
So first up today is the Office of the Chief Medical Examiner.
Okay. Good afternoon, Dr. Gill. What we're going to do is just briefly go over some of your responses. They're pretty, they're not, you wanna just give an oral presentation? And thank you very much for getting them to us on time.
No problem. I assume you can hear me okay. I want to make sure. Yeah. Okay. Yeah, no, I mean, I think, our kind of the stuff we submitted probably should kind of cover it all. I think the major thing for us at this point is the additional medical examiner, just to meet our autopsy numbers and to make sure we maintain our accreditation and proper quality of work and turnaround time for reports and so forth.
Mm-hmm. Mm-hmm. Does anyone in the committee have a question?
Well, it is a pretty competitive job market out there, as you can see from some of the data we submitted, that there are a lot of openings around the country, and that's really driving the salaries up. And so we do have 2 openings right now, and it's been a kind of a challenge to fill those. I think one thing with medical examiners, when they look at a new office, if they see that they're not sure how well it's going to be supported, or if they have enough potential positions, they may hedge away a little bit. So I think having that extra spot that really will get our numbers to a very reasonable level might be another incentive to get people to take a look at our positions.
But we have 2 positions that are funded and unfilled. Am I correct?
That's correct. Yes.
Okay. I don't want to revisit a painful past, but it wasn't that long ago that we earned a not very good reputation when we lost our accreditation. So that might even make it worse in terms of recruiting. You noted though that you think perhaps adding a 3rd might help.
Yeah, I think it does kind of send a message to those potential applicants out there that that there's support for the office, and that we do recognize that we're doing more cases probably per medical examiner than we should be, and that the state has seen that, and they're willing to support the office so we can get more people and make it a very reasonable, I think, appropriate level for autopsy numbers.
When we met with you last time, not this year, in the previous budget session, you had suggested that converting some of the part-time positions to full-time would help your office, and I believe we recommended that happen. Did that happen?
Yes, so we converted one of our photographers to a full-time position, as well as one of our IT people. Our autopsy numbers have pretty much doubled in the last 5 or 6 years. And so we needed 2 photographers down in the autopsy room to help us make sure we do proper documentation of our autopsies. We really are struggling facility-wise. I know that's not an issue for you folks, but we've really outgrown this building, and that's just putting a further stress on our work.
But we did recommend that they'd be full-time, and you did do that. So that helped a little bit.
Definitely. It certainly did. Yes.
Okay. Does anyone on the subcommittee have any further questions of the medical examiner's office? Nope. Okay. Well, thank you. Happy Friday.
Same to you. Thank you very much.
Thank you.
And, if we have any other questions, I'm sure you'll hear about it. We're all
Absolutely
concerned.
Great. Thank you. Thank you for your support.
mental health and addiction.
Good afternoon, Representative Dillon. Nancy
Good afternoon.
Navarrete, Commissioner Demas, thank you. I have with me Cheryl Aurora, who's our CFO, and Mary Kate Mason, who is our Director of Government Affairs. So if you like, I can just jump in and bring us through the questions.
Well, you did get them to us in a fair amount of time, didn't you? I'm trying to.
Yep.
They were very good, Madam Chair. Yes. They get a gold star, my friends at Demas.
There were some departments that were not very good, but I believe the subcommittee people were generally pretty responsive, and I think you were very responsive. Why don't you touch on the highlights, Commissioner?
Sure. Question number one, somebody asked about the YAS services. So I won't read it through, but we serve young adults 18 to 25, over 1,200 clients a year. About 277 of them are served with residential levels of care. The others are all served with wraparound services in outpatient. We do, as you probably know, have a 17-bed inpatient unit at CVH, and the director listed out some of the services if anyone is interested in taking a deeper dive. So that's
right, this is really just a break. I think it was a question about what you do, but it could be helpful to us because we did have testimony asking for an expansion there. I don't know if that's going to happen, but that's helpful. Any questions about the first question on the list here? No? Okay.
Okay.
The next is the discharge.
Yep. Question number two, a breakout of discharge and home and community-based services funding. So the first part of the question is our discharge funding. So as I explained when we had our hearing, the discharge dollars are very helpful in assisting us in transitioning individuals from the highest level of care, hospital level of care, into the community. And sometimes that takes very specialized services that we tailor for each individual. So you can see the little chart there. Our appropriation was $34.5 million, and it goes up to $40.945 in fiscal year 24 and 25, based on the recommendation of the governor's budget. So that number includes both annualizing the funds that we got last year in 23 and adding caseload growth. Anyone have any questions on that one? Okay, the next one is our home and community-based services SID. So that is a partnership with Department of Social Services, and it's really an extension of the MFP program. So MFP is run by Department of Social Services. Individuals that meet nursing home level of care are served through that program for 365 days, which is a year. And then if eligible, they will be transitioned if they are one of our folks as SMI, still meet nursing home level of care, they'll be served under the waiver program. And we provide lots of wraparound assistance, skill building, case management, meals, chore service, in-home counseling, anything a person might need to be successful in the community. You can see our appropriation in 23 was $25 million, and that goes up to 26.3 in the governor's recommended budget for 24 and 25. So that does give us caseload growth to be able to serve 30 more folks in each of those years.
Okay.
And we do not have a wait list. Somebody had asked that question.
Mm-hmm.
Any questions?
Any? No. Next, the ABI.
Okay. So acquired brain injury program. So just to clarify, we are not the agency that runs the waiver. We run these services to support individuals in the community. We also have beds at CVH to assist individuals as well. You can see our appropriation in 23 was 8.5 million, and the recommended budget goes up to 9.1 and 9.2 in fiscal year 25. So this incorporates the money that was given to the private nonprofits in terms of COLA, and the increases are reflected there. So individuals in this program not only have an acquired brain injury, but are part of our population. So they have a co-occurring disorder of a mental health condition. And so we have the content area to be able to help folks that suffer from both. We have community integration specialists positioned around the state. Each state operated LMHA has a CIS, or a community integration specialist, as well as intercommunity and USI out in the northwest east corner. I mean, you can see some of the services: consultation, specialized substance use services, training, education, and advocacy. Any questions?
Any questions on that? Next, Hispanic behavioral.
Sure. So this one, I know you have a particular interest in, Representative Dillon. There's two pieces here. This answer actually only covers the Hispanic clinic at CMHC. I know you're familiar with that fabulous resource. So just that resource alone is $2 million that we have in our budget. If you take a step back and look at the entire Latino behavioral health system, another program I think you're a fan of, we have close to $6 million in that program. If you take it all together, that includes our private nonprofits across the state. You had asked specifically about the new money that was infused into that program last year. That includes 4 CHWs that were added to expand access to behavioral health services in the Latino Behavioral Health Network across Greater New Haven, really with a focus on health literacy and increasing access points. We also funded a Latinx peer support program at Fellowship Place to expand recovery-oriented and social rehab options for Spanish-speaking clients. And the CHWs are placed at Iris, Junta, BH Care Bridges, and Casa Atenel. Any other questions?
Yeah, the original intent of that was to change what had basically been a translation service into a program that would train clinicians. And that was a while ago. I believe there was a point at which there was an ambition to make this serve a larger number of camps, but the budget challenges in the last administration prevented that. So this is helpful. Any questions about this? No? Okay. Thank you.
Okay, the next one is about, we just had a general question about detox. So the new language that we use to describe detox is withdrawal management. That's the new clinical language that we use. We provided you probably with a little bit more information here than you asked for, but when you see the WM there, so right above the total, it says ASAM 3.7 WM. What that means is the American Society for Addiction Medicine classifies, they call this level of care 3.7 withdrawal management. For that level of care, we have 7 programs. And when you count all those beds together, we have 158 withdrawal management or detox beds. That's in our private nonprofit system. Then if you look down to our CVH system, you see the 2 3.7 withdrawal management programs there, one at Merritt, one at Blue Hills. So that's one in Middletown, one in Hartford, 30 beds and 21 beds. So that's detox or withdrawal management.
Okay. Are there any questions about this? Okay. Did someone have a question? No? Number 6.
Okay, you also asked about our opioid related programs. So this is a little snapshot, certainly not everything that we do, but our levels of care really are not determined by the type of substance someone uses. So if you're misusing alcohol or if you're misusing an opioid or a benzodiazepine, you have access to our full continuum. So that includes withdrawal management that we just discussed, residential, intensive outpatient or outpatient services, recovery supports that we offer across our system of care. There's a link there that shows, I had talked about our front-facing website that shows you the beds available. That will connect you to that. We also really have expanded our outpatient medication assisted treatment throughout our system, and that is both buprenorphine and methadone maintenance. We have 30 methadone clinics across the states. Most of our docs are have training and familiarity with being able to prescribe Suboxone or naltrexone. We have outreach. We fund outreach to individuals through our mobile vans and through street-based psychiatry. We partner through both the ADPC, the Alcohol and Drug Policy Council, and different contracts that we have with DOC, for example. So we really partnered with DOC for them to be able to expand their medication-assisted treatment program within jails and prisons. That's been very successful for them, and they've taken that across the finish line. We partner with DCF, CSSD. We do some diversion programs. We have a 24/7 access line that will help folks with transportation to detox or withdrawal management, as well as placement and trying to find a bed if they need help doing that. We have a very an award-winning campaign, Live Loud, that targets individuals using substances, gives resources for families who might be interested in learning more about addiction and what resources are available out there, as well as messaging around harm reduction and how to, if you must use, how to try to use safely. Also in giving people information about Narcan, which is a life-saving medication. Some prevention and harm reduction work. So as you know, you're probably familiar with the RBHAOs. They operate across the state to do Narcan training and distribution, as well as some mental health events as well. We work with community coalitions on the ground in specific municipalities and health regions to get the prevention message out. We work with people after they overdose, with families who may have questions, or trying to get those folks connected to care. We've distributed 30,000 kits of naloxone, I believe, at last count, and fentanyl strips. We have lots of recovery supports for folks. So in the ED, we want to catch folks no matter where they enter the system, the physical health system or the behavioral health system. If folks need sober housing, we try and help them paying for that as they get out of care, so that we know folks are strapped for dollars, and safe housing is important. We have some faith-based initiatives and some community initiatives. One of them is called Amani Breakthrough, which operates in Bridgeport, New Haven, and some other communities around the state. Employment.
We do have a question, Commissioner.
Oh, sure.
Representative Miller.
Thank you, and I apologize for being off screen, but I'm en route to the Capitol. Yeah, I'm just you did mention mobile outreach for a minute. Could you talk on the children's mobile outreach and how they're available, and the ways that you're putting that information out?
Sure. So I was speaking in this question to units that go out into the community and give recovery resources to folks to try to engage them into treatment for substance use. We also have mobile crisis teams that work with people who are in mental health crisis. And there are teams that cover the state on the adult side. So DEMA serves 18 and older. DCF has teams on the child side for kids 17 and under. We work very closely with our partners. We have regular meetings with DCF, and actually both systems of care have received national recognition for the work they do in the mobile crisis space.
Okay, and could you share the hours for mobile outreach and how we can let our municipalities know how to contact
Sure.
for any kind of emergencies?
Sure. So I don't know all the hours for DCF, but certainly 211 is a very easy number to remember, and 211 can connect you to all of those resources, and they can talk anyone through that. Our adult side, with the money that we have been given last year, and that will be continued into the next biennium, hopefully, will bring the adult system, barring the workforce shortage, to 24/7.
Okay, and is there any improvements being, like you said, 211, and unfortunately, sometimes when you call 211, people wait quite a bit. And as in my daytime job or nighttime job, I've actually called 211 trying to reach someone in order for someone to get help. And it's very difficult for people to get through sometimes. Is there any streamlining that's being done that can correct that? Because I can get through 211 as a police officer, but as a normal constituent, my constituent can't get through 211 as quick as I can. And that seems to be something that's happening continually.
Yeah, I appreciate that question. I think there are longer waits for 211 as it relates to perhaps housing resources. What we've found in terms of 211 and access to 988, I'm throwing all these numbers at you, but 988 was a federal mandate that was implemented last July. We brought it up very successfully. If people are in emotional or substance use crisis, they can dial 988, and our response times are approximately 4 to 10 seconds. So, and that is tracked at a national level, and those numbers actually are reported back to the governor's office, is a priority at the national level. So we know we're doing a very good job in that space.
Okay,
I wonder, Commissioner, if there was a way to look into Representative Nolan's concern about response time. I think your response is really helpful, but it may not apply to his situation. I don't know.
Happy to talk anytime. Happy to also host a call with United Way and yourself, who, to have them explain how they keep track of those times. And even if you have a particular case, they can track down to the number. So if you have somebody's phone number and when they called, I can have them research that exact call for you.
So if I can just ask one more question. So are you saying that people should call 988 versus 211 in a situation when there's a crisis for mental health?
If there's a mental health crisis, yes, 988. There's no wrong door, by the way. So it's the same vendor. It will end up in the same place. 988 is for crisis. 211 has a broader responsibility. So 211 gives resources. They can triage to crisis. They also do work for DOH and the CANs regarding housing. and they're just a general way to get resources about social services across the board.
Okay, and I think maybe that might be some of the confusion, where people are thinking 211 is the answer for all when it's not. It's 988 that is the better number to call. If you're going to get the 4 to 10 seconds, then that's worth people knowing more than 211 to call 988 in crisis situations.
That sounds good. Maybe you can follow up on that offline and see how that squares. We have a couple of people waiting here. Walker, Exum, and Delaney are next. Representative Nolan, are you satisfied?
I'm all set for now. Yes, thank you.
Okay, thank you. Representative Walker.
Thank you, Madam Chair. Good afternoon, Commissioner.
Good afternoon.
So I'm going to go back to the mobile vans, and I see that we have multiple uses of the mobile van. The one I'm most focused on is the one that we are using as a dispensary for medications.
That has not happened yet.
That has not yet. Okay, so where are we with that?
So those regulations, to my knowledge, have been passed on to OPM for review by DPH.
So OPM has the regulations, and you've signed off on them, and DPH has signed off. So now it's just up to OPM.
Yes.
Okay. So with our dispensaries, the ones that we do, people that come to get, let's say they get methadone, what do we do to oversee the effectiveness of each one of the clinics? How do we measure their successes?
So there are front-facing report cards on our website. Mm-hmm. So it shows person served, connect to care, how many folks stay engaged. So all of that is front-facing. You can look up any center you'd like on our website, and we can certainly forward that link to you as well. We also have, it's a Medicaid service, but under DEMIS, we have I know you know this, the SOTA, who is Gina Florenzano. So she is responsible for approving things like exceptions during a snowstorm, mm-hmm. or if there is an issue with a clinic, being the liaison between CSAT and the state. So we don't license the clinic. The clinics are licensed by DPH, but we do play a role in monitoring and interacting with the clinics regarding their services and hours and take homes and all of those kinds of things.
So I think you and I had talked about this once before, and I checked on SAMHSA's website because they do the regulation on what we require them to provide in this. And help me remember, they require, how often do they require urine tests?
8 tests a year.
8 tests a year, okay. And how many counseling sessions are they required?
1 session a month.
Okay, how do we validate that?
So all of that is now, there are claims runs that can report out through DSS. There are specific codes for every piece of the treatment that the clinics, of course, there's a claims lag, has to go through the system, but it used to be 1 rate and 1 bill per month, or per week rather, and now that is split out. So I believe that DSS has the capacity to tease that apart. But we also do, and DSS can certainly do as the payer, audits and chart reviews, those kinds of things to make sure everything is documented properly.
How often do we do those audits?
I don't know what schedule they're on. I can certainly find that out.
I'd be interested.
Mostly probably annually or every other year. Yep.
Okay. So when we have a clinic that does not seem to be working well in their environment within a certain part of a city or a town, how do we handle that when we don't consider them a good neighbor? What do we do? What is the requirement for us to have them cease and desist?
Well, I think you might be talking about something that's slightly out of our purview. It might fall into zoning and regulation that way. If somebody is not following the licensing regulation, then that would be something that DPH would comment on, and they do their own audits and site visits. If there's a critical incident, something happens and DPH feels it rises to an occasion for them to visit the clinic, that is another vehicle. And then we have our regular interactions with the methadone clinic directors and with the staff related to services rendered. And if there's a problem with exceptions or take homes or hours, that would fall under our SOTA.
Okay, so I know that there's a neighborhood in New Haven that has been complaining about a bad neighbor. And they've written to DPH. I don't know if they've written to you, but they've written to DPH, they've written to us, and yet they still are managing themselves the same way they were before. I won't get into the details of how this, but there's got to be better control for the people in the neighborhoods and the districts. And I understand zoning is one thing, but zoning is not going to evaluate the effectiveness or the violations that those facilities are doing. And please understand, I don't believe that all of the dispensaries are doing that, but this one is. And we have had numerous discussions about it. We've asked the city hall to intervene. We've tried everything possible that is appropriate. And yet the facility is still operating and in the same vein. What do we do? And that's what we are asking from you and from Commissioner Jitani. And if we have to, we'll go to the governor, but we want them to be a good neighbor. But we also want to make sure that people are getting services that are going to help. Sometimes I think the methadone program is not meant to get somebody off of drugs, it's just to maintain them. And I know it's called maintenance drugs. That makes me worried because I think one visit, and we talked about it, you said I needed to contact SAMHSA, but we could do it in Connecticut. We don't have to wait for SAMHSA to give us those guidelines. But if you think about addiction, in addiction, you have to have counseling. You have to have an opportunity to communicate with someone. And then you also have to be monitored. And 8 urines a year and 1 counseling a month, I think is inadequate. So I think this conversation, and I'll stop right here because it's gotten longer, but we are at a point where we're not exactly sure how to, and nobody seems to be reaching out, even though I've brought it up to every single person that has been mentioned today, that this is a problem. No commissioners have reached out to me to talk to me about how they can work with this and how we can make it better, because that's what I expect the commissioners to do. So with that, thank you, Madam Chair. I hope to hear from all of the commissioners that are involved in this so that my community, like everybody else's community, gets heard in the appropriate way. Thank you.
Thank you, Representative.
Thank you, Representative. Representative Exum.
Thank you, Madam Chair. Good afternoon. Commissioner, I wanted to follow up a little bit on where Rep. Nolan was speaking around the 988. I have a couple of questions. So is it the case that if someone is 18 or older and there is a 988 called and there is the connection is then made to someone in Demas, regardless of whether there's a substance abuse component to it?
Correct.
Okay. Okay, so because earlier when we had the panel, it occurred to me I was trying to tease out whether or not DEMAS was mental health and substance abuse, mental health and or substance abuse. And I thought it was both.
Yeah.
But in this case, the way that the dispatch is working with 988, it can be either or. Or it's really mental health. It really is what that is. You don't know if it's a substance abuse part. It's someone.
Most of the crisis calls are around mental health, but there is no wrong door. So if you're in a substance use crisis, you can also use those numbers. It will get you to the same people.
Right. Okay. And then you said that the 988 was rolled out, like you said, in July of 2022. And so now we are waiting to fully implement this in Connecticut so that we have the 24/7 response time. My question is, and that is something that if in the governor's budget, you think this funding is appropriate, the 5.3 million?
So there's two pieces to the crisis response. The first piece is the centralized number. Yes. So whether you call numbers that and we didn't want to take away anything from people. So if they're familiar with local numbers to access their mobile crisis, that remains in effect. It's really important to have no wrong door. If they call 988, that will get you help. If you call 211, that will get you help. So there's that piece. That piece already runs 24/7, the call line, the centralized call line. What we're preparing for are increases in that call line. So we're projecting out. So things will happen over the next year. Like students will have 988 on the back of their ID cards.
Right.
More people will become familiar with advertising about 988. There's been more conversation about mental health and wellness, and that has reduced stigma and increased the conversation. We have some campaigns about mental health and wellness. And since it's such an easy number, 988, there has been an increase in calls to the line. So we're using our data to project out. It's about 15% increase we're looking at next year and then the following year. And so the money that's provided in the budget will help with that transition as the volume increases.
Excellent. Okay. And I'm happy to hear that because that was much of what was in the legislation that we did last year. So I'm happy to hear that's in the process of being implemented. My other question though is, and a concern of mine that I have highlighted is currently, if you call 988 and they do that wonderful response time that you're saying, that is very, very quick, but there seems to be, it's been reported to me, the breakdown did not occur on the call and that crisis person being great, which is at the national level, but transitioning that call for local service, particularly if it's the weekend, that person did not get any kind of support whatsoever. So my question is, what is happening now if someone calls and the hours aren't, it's Saturday evening and they get the 988 transfer? What happens to that person who is potentially suicidal, which is why they're using 988? What is happening?
So let me clarify. So if the call goes to a mobile crisis team, there is always a 24/7 telephone response. So you always have access to a clinician. What you may not have access to is a deployable person to go on the scene. So that's where it's built into the budget to build up to 24/7 deployable clinician, and where we are, quite frankly, facing some difficulties on second and third shift because of the healthcare workforce shortage. It is a challenge bringing those second and third shifts up, but we are funded for that, and we have a plan for all of our mobile crisis teams to get to 24/7 deployable clinicians.
And so that call, and thank you for that clarification. So that phone call that the person has with someone who may be available, that you're able to pull up just in case something needs to take place there. If that person is in acute distress, what is the response potentially from that person on the phone? Because that's the person's still in distress, and maybe that's not the same as having someone come to their home. What would be the response to that? I'm really tracking closely a situation that I'm very familiar with.
Sure. So 3 things can happen. If there is a deployable clinician and the clinician assesses it safe to go out by herself or himself, they can go to the scene and intervene with the person. If they assess that the person may be dangerous, then they can also loop in police, so they can accompany police to the scene to help that person. If there is not a deployable clinician, then it's probably a phone call and then a 911 call to make sure that the person is safe if it's escalated to that point.
And finally, thank you for that. Would they do a follow-up after the fact, or is there a follow-up expected? Okay. So I think respectfully that piece of it, I see it still underway, and from what has been reported to me, there was a lot of that did not take place, and I'm just grateful my constituent didn't end up in a worse situation than they did. But I just,
again, certainly reach out to us offline if there's an individual case that we can look into with you or with the family. We're happy to do that.
Thank you. I'll ask if they'd like for me to disclose that. Thank you so much. Thank you, Madam Chair.
Thank you, Representative, and thank you very much for your line of questioning. I think it's really helpful, and I wonder, Commissioner, if you can't do it now, if you could get back to us, this issue about the second and third shift being affected by the shortage of clinicians. Is that true statewide, or certain parts of the state having more struggles with coverage?
It's national and statewide, yes.
No, but I mean, in terms of our own boots on the ground situation, is there more of a problem of availability, let's say in Eastern Connecticut than in Fairfield, or it's statewide? Is there a regional difference in terms of shortage of clinicians?
It is statewide. Statewide.
Okay. Thank you, and thank you, Representative. It's Representative Delaney.
Thank you, Madam Chair, and I just want to start off by thanking you, Commissioner. It's a pleasure to virtually meet you. I'd like you to thank you for being here, and to thank you and your staff for your service.
Thank you.
I out of respect to your time and the time of everyone here, I don't want to belabor any points, but I would like to echo and caveat off of the statements from Representative Nolan and Representative Exum. I've also had some issues at both the tactical and operational level working with 211, and similarly, not as much with 988. At the tactical level, I've had some issues with some constituents who I've worked with here in Stamford, where I represent, trying to get access to service. And at the operational level, I've had a few issues with OFA trying to really track down the individual light items that go to United Way for those constituency services. So I would just like to quickly say, if there is going to be any follow-up between, your office or other offices and Rep. Nolan with 211, I would like to be included in that. And even potentially, if we could go down, because I have had some issues with transparency in terms of light items. But thank you, ma'am, for your service.
Thank you. Thank you for the questions.
Yes, ma'am. And please feel free to include me in that follow-up.
Thank you. And any information that can add to our knowledge, if you could share that with the committee administrator as well.
Okay.
Thank you. Question number 7.
Okay,
And thank you, Representative.
the substance use demonstration project. So this is a collaborative project with DMIS, DSS, the Medicaid Authority, CSSD, who also uses residential beds, DOC also uses residential beds for substance users, and OPM. So historically, our beds in the both mental health and substance use, but they have not been Medicaid billable. So if you have a site that's over 16 beds, those are considered IMDs. That's presented in the write-up in front of you. This project waives that exclusion, and we can now get federal match for the services, which allows for an infusion of money back into the substance use continuum. So it invested about $70 million into the continuum. The services are more robust, and there's a lot more clinical and recovery supports available for people in terms of the staffing patterns, a more thorough evaluation of individuals as they come into care to make sure they're at the right level of care. Now, all that being said, we have to weigh everything with the staffing challenges that our providers are facing. So I went through some of the levels of care in the previous slide. This applies to withdrawal management, which is detox, our intermediate levels of care, our intensive levels of care, our halfway houses, some of our ambulatory services. Really has brought the full continuum to Connecticut, built upon it, and has been a collaborative between all of the departments mentioned.
And any questions on the seventh? No? Okay. Number 8.
Okay, 8 we weren't quite sure here. Someone mentioned the Social Equity and Innovation Fund. This is not something that funds the DMIS budget, but I think maybe folks were confusing it with the Cannabis Prevention and Recovery Services Fund. And so when we get to the cannabis question, we can take a look at that.
Okay, it sounds like we're at the cannabis question.
Okay, so someone asked about cannabis and tobacco funding. We do have a federal grant, tobacco retail compliance inspection effort, which funds all of our compliance efforts. The award in 23 was almost 1.5 million, and in 24, 1.58 million. So that addresses the tobacco piece. The cannabis piece is a total of 2.3 million in 24 and 3.3 million in 25, and it brings you out to 26 actually. But this will pay for 3 staff to help run these programs. It pays for prevention activities, for a big media campaign that we will be kicking off, and the compliance efforts, as I've mentioned.
Any questions? Okay, number 10.
Okay, military support program. So this is a program that's been running for several years. We have 2 community clinicians and 2 community case managers. With money that was infused back into the program last year, we were able to hire that second community clinician, who happens to be a woman who is a veteran of the Navy and who has already started engaging with female vets and family members anywhere across the state. We have a centralized call line that helps folks with resources for veterans. The folks that we employ in this program are very familiar with military culture. We have other parts of the program where we have 19 embedded clinicians, which go to events at the National Guard and provide resources, outreach engagement. Folks can continue in individual sessions or be referred to clinicians, again, with expertise in military culture. With the additional dollars last year, we were able to expand that network of providers with this specialty so that if folks want that confidentiality, that they can seek counseling services in that way.
The reason I asked this question because well, this is a program we rolled out in 2007 because of the invasion of Iraq, and at that time, our military department did not have benefits for, beyond 2 weeks when they came home, and it's designed to do family support. But there had been the Women's Initiative really specifically happened because of the literature indicated that returning women had a higher suicide rate, and that our reentry program seemed to be geared towards substance abuse issues, but that there may have been some sexual assault, trauma issues, and therefore the outcomes in terms of women who were coming back from theater was very disturbing. They had a higher suicide rate than the men did, and that was a modest amount of money, I know, but it was an attempt to support your department in trying to help people. This particular program is within the managed service system, and so you'd have to know it's there. But there has been some conversation about outpatient support coming out of some folks in the military department. Have you spoken with them about that?
I'm not sure what you're referring to, but there is a component of this program where individuals can be connected to outpatient clinicians with an expertise in military culture.
Okay, and I may follow up on that, but I know some folks in that part of the state government were talking about that, strengthening our outpatient a while ago. I don't know if it went anywhere, but I may follow up offline on that.
Okay.
Okay. Any questions? And thank you for the work that you did with that, given that the cuts were pretty severe during the previous administration. You really squeezed those dollars.
Thank you for keeping it alive.
Number 11.
Okay, so this is just a general question. Folks were interested in some of our prevention services. So this is just a sample. We have a lot of wellness services. We really take a public health approach. We're responsible. So although we're responsible on the treatment and recovery support side for adults age 18 and over, in terms of prevention and wellness regarding mental health and substance use, we're responsible for the entire population. So we do a lot of public health messaging about wellness and substance misuse, a lot of education. We work with the RBHAOs, the Regional Behavioral Action Organizations, who work with their local prevention councils at the local level. So we know that, the Southeast may be different from the Southwest, and they may have different needs. And so through these partners, we're able to tailor our prevention efforts that way. The Connecticut Clearinghouse, Governor's Prevention Partnership, tobacco merchant education, et cetera. We list a bunch of wellness campaigns that we've implemented that have been successful. The Be in the Know Connecticut campaign I mentioned during my testimony, that's the one folks are interested in regarding cannabis.
Any questions of the commissioners? No? Okay. Number 12.
Okay, I think we kind of covered this one already, but this is related to the suicide prevention hotline, which is 988. In terms of our suicide rates, we know any death is one too many. Connecticut is actually 45th nationally in terms of the number of deaths. So we do really well with our suicide prevention initiatives. Our rate is really low compared to other states in the country. The governor's budget maintains and expands our 988 services, as I have already said. I don't know if there are any additional questions, but
I don't see any questions. No. Number 13.
So this is just about additional programs, and we feel like the budget is very generous and really has continued all of the funding, or most of the funding in ARPA, which is the next question. So we are very grateful for the proposed budget. Question 14, I don't know if somebody stopped sharing the screen, but it goes through all of our ARPA initiatives that were started in 23. And you can see, if you look, this is page 15, I think, on your, not sure on your version what page it is, but all of the initiatives, the mobile crisis services, case management, the forensic population, respite beds. Here we go. There we go. So all of these, it lists it out, takes it from the budget, and you can see in the right-hand column, confirms that they are continued in the governor's proposed budget. The one-time funds or the EHR funds and the public awareness grant. And then as you scroll down, these are some one-time projects, some earmarks that were called beneficiary awards, Clifford Beers, Pathfinders, Fellowship. Those were for financial need, and they were one-time awards. And then, of course, the private nonprofit providers, their COLAs are carried over in the governor's budget as well.
Mm-hmm. Any questions about that section? That seems pretty straightforward. The number 15.
So there was a question about the number of federally funded staff, and we have 30 positions, 2 that work with our opioid services group through the state opioid response grant. That's a federal grant. And then the 28 positions for the FDA compliance program, which is the young folks who work with us to do those checks, those compliance checks.
Mm-hmm. And any questions from the subcommittee? Representative Ekstrom, I see you there. Yeah.
Thank you, Madam Chair. Just one quick question. Around the public awareness grants, I'm assuming that includes things like the 988. I don't know if there are other pieces to that. And around like the progress, if you can just give us a quick update as far as what that looks like, please. Thank you.
We have actually chosen a vendor, so it hasn't been launched yet. So we're at the point where we have a vendor. And we'll be working with that vendor going forward.
And is it strictly the DEMIS piece of it, or do you overlap with other? Do you overlap with DCF and not, or United Way or something like that with this?
We oftentimes will try to make sure that our messages do not contradict one another. So we'll work with, we just worked with DCF around some substance use messaging for parents and children. We work with DPH around our messaging. So we are in contact with one another to make sure that our messaging all makes sense when it's taken together.
But your piece is strictly DEMIS. This is the DEMIS piece of it. Yeah.
Yeah, since we do public health interventions for prevention across the lifespan, yes.
Across the life. Thank you. Thank you so much, Commissioner.
Thank you. Thank you for your questions.
Thank you, Representative. Other questions? No, we're 1 minute shy of 3 o'clock, so we're clocking in right and managing time pretty well so far.
Madam Chair, I have questions regarding the questions I sent over that weren't reviewed.
Oh, absolutely. And they had a special label on them, didn't they?
They did, yes.
Everybody else is anonymous. Why don't you do that?
Nope, send them over, put a name on them. Here you go. So if I may, Madam Chair, thank you for the detailed information on the vacancies. I wanted to ask, you have several hundred vacancies in the organization, and a lot of them are healthcare related. So I'm looking at the built-in dollars there because they're all full-time, full-year FTEs, and we consistently run vacancies in your area. So I'm wondering if, do you have dollars planned in for your healthcare agencies for like travel nurses or consultants to help fill roles in those agencies that are outside of the personnel services, just regular headcount lines?
Yes, we do. That would be professional services.
Okay, so professional services. And do you have a lot of, what are your dollars that are in there this year for support services for those?
Cheryl, do you happen to have that?
I do. Our fiscal year 23 appropriation is 22 point, our estimated spend is 22.4 million.
22.4 million. Okay, and what do you have in there for ongoing for next year?
For next year, we are, the governor's budget recommends 16.5.
60.5, 60? 16.5. Okay, and then one of the questions that I asked was around lapse, and you just referred me to the comptroller's budget, and I'm asking everybody if you could actually just give me your numbers rather than me trying to dig through that report and find them. So what I'm looking to understand is, did you have any lapse dollars as of 6/30 last year? And if so, what areas were those lapses in? And are you anticipating any lapse dollars for this current fiscal year?
So if you do click on the link, I know it is a lot of information, but it brings you directly to our page, which is 30, which is page 30 and 31. And it shows you the lapses there. I think it's 3.4 million.
3.4 million is what your organization has lapsed. It actually just brings me to page 1 of 100. So that's why for the people who just pointed me there, I'm asking them to actually give me the numbers, because to try to go through this and figure it all out is it's too much with not enough time.
Okay.
So let's see, I am looking to see if you could just provide the lapse dollar amounts for the 6/30 amount, and then if you're on track or are you expecting lapses again this year, and if so, how much?
I don't know what it'll look like at the end of the year. We do sometimes use the option of going to FAC. For example, if we are underspent in our PS line, we'll be able to transfer some of those dollars to professional services, and that's what's happened in the past. So we can effectively use those dollars for contract workers, for example.
Do you have any lapses that are not personnel services then?
Cheryl, do you want to speak to that in a general way?
Not personal. I think that the one I would mention is the home and community-based services.
I'm sorry, I can't understand what you were saying there. You got really mumbly at the end.
The home and community-based services account tends to lapse money, and so that's being adjusted in the government budget.
It has been adjusted in the government governor's budget.
Yeah, her volume is her audio is a little off.
Okay. I think that is all that I have right now. If you could just send over those numbers with the lapse information, I would appreciate it.
Sure, we'll get back to you.
Thank you very much.
Thank you, Representative. And I wonder, maybe I'm mixing this up, but if I remember correctly, I thought there was a time that we were paying for professional services out of the OE account. Is that true? And there were some expenditures in OE, maybe not this year, but in the past, that I thought could have been in the PS line if anybody would work for us, or if we could find anybody. But and maybe it was school clinicians of some kind. Does that ring a bell? No?
So we did things like paid for COVID screeners. Correct me if I'm wrong, Cheryl, out of OE. So that brought our OE number up. We no longer have that expense. So that's one example. Or like I said, we would FAC money from PS down to professional services because of the workforce crisis.
Yeah, the paying for a clinician through professional services costs more than having a full-time employee. Is that true?
Well, the hourly rate, of course, is going to be higher if you're doing it through a locum tenens type organization. But there are times too when we have to run the hospital and we don't have a choice, and so we'll have to get somebody that's a contractor. Yeah.
I'm not criticizing you, but anyway, I jumped in on your question, Representative Nuccio, but you really opened some interesting lines of inquiry. So thank you.
You know, yeah, I'm good. Thank you though for the add-on, because it's this is why I asked the questions. So thank you.
Mm-hmm. Okay. Any other questions? Nope.
Okay. Thank you.
Thank you very much. Now, I haven't,
the DDS team is here.
Good afternoon, Commissioner Chef. And Christina, you're in charge, sort of. I don't know how much we can get done today, because I didn't think that we had gotten responses to questions and some other things.
They got approved. They got approved late yesterday and sent late yesterday, like late in the evening yesterday.
Well, they were Madam Chair, they were forwarded to subcommittee members around 7:30 this morning.
I see. Okay, I'll take a look at that. Well, do you want to quickly go through some of your responses?
Not sure where you'd like me to begin. I can definitely do it quickly. It is Friday after all. I think we may all after this week be feeling that.
Well, I apologize that I'm not doing justice to your response.
Well,
I may have read it last night and forgotten, to be honest. But
no, if you got it, it came very late last night. I don't want to misrepresent what we're talking about. We're in the darkness of night. It was forwarded to you, but ahead of midnight. But we had a lot with House Bill 5001 and a few other bills that are running around over there, trying to get all of our testimony approved. So I apologize that it got to you that late, and we will try and do better going forward. So I think on a number of these issues related to some of the other bills that we will be having lots of conversation about parts of this, but I think I can do it justice if you'll bear with me. You're gonna look at the side of my head so I can use my big monitor and read what's in front of me, because what Kevin is now sharing with you shows up on my laptop and I can't see it well. So if you'll indulge me, we can start with number one, Representative Dillon, with the state ARPA funding. And the status report on the 24 million, and we refer to it as state ARPA as opposed to the HCBS ARPA money. So currently, department is working on an RFP regarding community engagement, an application form for the improvement of camps, which should be out at any moment. Waiting on Vista to return a signed document to issue the $500,000 indicated for them in last year's budget. The application form for the stabilization grants, and in process with the 3 million on the family grant process for respite, increasing respite. We spent about half of it so far, of the 3 million that was allocated there. which given where we're at in the year, we'll probably spend the rest of that as we get into the end of the school year. Southbury training.
Any questions about the ARPA funding from any committee members? Okay, go ahead. Sorry.
Southbury Training School, a topic you and I love to chat about from time to time.
Yeah.
There are 125 individuals there as of March 6th. I think even as of today. The current per diem costs at Southbury are now $1,453. The number of community placements in recent years, in the last 5 years, we've had 13 people move into community-based settings, hampered by real estate market, workforce shortage, and COVID. Placements anticipated in the next biennium, we have 10 individuals who ought to be moving rather soon, but certainly within the biennium. And that should be one person moving individually, a 6-bed home and a 3-bed home, I believe. And the improvements at Southbury, the safety of the individuals continues to be paramount. We have had to make a number of other, when you talk about improvements, I'm assuming you're talking about physical plant or quality of care.
I spent like, I think 10 years obsessing about the workers' comp over at Southbury, so that injury prevention and any kind of safety issue involving the residents and the people who work there have been kind of an ongoing thing with me.
Sure.
So that I guess that's what I was thinking.
Okay.
Obviously it came more front of mind during the pandemic.
Yeah, so we fared rather well during the pandemic compared to places like Southbury. Not that we didn't have people get it, but we had one person listed as dying from COVID, but was in palliative care or near end of life care anyway. But we did pretty well. There have been some issues. For those of you who read the papers out that way, we had to use temporary boilers for a short portion of time. And we had a fire at what used to be Personnel Village that was handled, and a couple other physical plant concerns, all of which have been addressed and within appropriation, and some cottage moves, some new hires, which I think helps de-stress the existing staff and give some relief to people who put in more hours than they would have liked through much of the last year and a half.
But in 5 years, we placed 13 people.
Yes. So the way the Southbury Settlement Decree, the Messier Agreement is written, the obligation for the state is to make sure that individuals have informed choice over the differences between living at Southbury and living in other settings. We are in compliance with the remedial experts reports on that. We continue to try and enhance that, and we're trying to do all sorts of things to try and pave the way for people to make a choice that's best for them. Many of the individuals who were there have been there a very long time, as you know. No one's been admitted there for a very long time, as you already know. And people are pretty happy with the supports they get out there. But we continue to work with a number of advocacy groups in the remedial expert to educate the individuals who live there and their families and their guardians about potentially moving. And we have a new concept that we put forward in the last 2 years to try and expedite some of this movement. I have called it if we build it, they will come. One of the things that has hampered us in the real estate out in the western part of the state is that by the process for the state to acquire a home to move people into is hard in a market where people are paying cash for homes they haven't even visited, and we saw a lot of that during COVID. So we went about and bought one anyway, without anyone having intent to move into it, in cooperation with DSS and a private organization called Corporation for Independent Living, and it is just about ready to show. And we're hoping that having a home move-in ready where people could sort of pick their grouping, will increase the number of people doing those types of placements. And if that experiment is successful, that's probably the approach we'll continue to take, because particularly with 5001 running, we'll need all the bed stock we can get regardless. So if individuals at Southbury don't move there, my guess is there'll be other people who will.
I did not ask you but I got some questions from our members who I think were stimulated by a public hearing yesterday that within another committee, the asking for demographics on the age, gender, and race of the people who are in Southbury, and the age, gender, and race of those who are on the wait list.
We can look into getting you that data. It won't be complete in many cases because people have to identify and can opt not to on some of that data. We can certainly give you the average age, length of stay, current ages. There's a lot of information that we can provide you, Representative, to give you a better sense of what's there. And I should also mention that we're actively engaged with a subgroup within DAS on developing some planning for how and in what way we may consider future uses of Southbury and for other purposes. So we're about a year, maybe 8 months into that. And hopefully we'll have more to share when we finish that. I've not yet presented to the administration because it's not complete, but we would start with presenting to the administration some of the options we've identified, and then hopefully we'll then be able to turn around and share some of our efforts there. We are looking. There is an end. There is an end to this process, and we're trying to do it planfully so we don't end up in some of the situations that have plagued the state for other facilities like Southbury when they have been abandoned.
But on the racial question, I think some of the concern was whether, and it comes up in another question, whether or not people are being defined accurately. Maybe there are some individuals who theoretically would qualify, but they're not being accurately identified. They don't have access to our system. I think that was what the thinking. And there were some very specific questions about the criminal justice system and whether or not some folks are ending up there who might be better served elsewhere. And that has been a theme of some questions that have been coming. And I know on a Friday afternoon, if you don't have the answer right now, you're not going to be able to come up with it in 5 minutes. But I think there will be continued interest in that line of questioning.
Absolutely. And Senator Austin and Rep. Walker have been asking us to follow up on that. I have a small amount of information contained in the written follow-up we sent today. And I think that some of, there are potentially, as we look at broadening or considering broadening definitions for eligibility, I think that that may begin to address some of the concerns the senator and representative have brought forward publicly to me on at least one occasion, and probably 2 or 3.
Maybe even under the current definition, a particular person who was depressed or who had diminished capacity in some way might be slotted into another system. I don't know that. So it's questions,
Yeah, we do track and get indications from corrections for people they would consider forensics, people who have issues outside of just, the kind of situations you've described, indicating to the administration to various agencies who they're tracking that may need services or may need a different type of support as opposed to incarceration. And there's some of that in the written testimony that we provided, or the written responses we provided. Question 5 talks about youth, and I think there's a little more in there about forensics further down.
Okay. Great, thank you. Next. Any questions from the committee about that? I'm sorry, I'm hogging the time there. But I did want to add that because I forgot to ask at the last session, and there is interest in that. Okay.
So I think we're on to number 3. We were asked for a breakdown of public and private facilities and also to differentiate between ICFs and CLAs, intermediate care facilities and community living arrangements. Community living arrangements being the statutory name for group homes in how they're referred to in statute. And as you can see in the table, there's 66 private ICF locations supporting 334 individuals. There are 760 private CLAs with supporting a little over 3,000 people. In public, we are down to, I think I said in my spoken testimonies, in the neighborhood of 35. It's 31 CLAs supporting 147 people. Our public ICFs, which for those of you not as familiar with this as others, include Northwest Center, Lower Fairfield Center, Hartford Regional Center, which is in Newington, and Southbury Training School. Those are the 4 remaining. We had 2 others previously. Those numbers are indicated there with the 4 ICF supporting 252 people. In those defined settings, a total of just south of 900 locations and just about 3,800 individuals supported. And Rep. Dathan has her hand raised before I go any further.
You say that like you're surprised, Commissioner.
Rep. Dathan, why don't you ask your question?
Thank you so much, Madam Chair. And thank you, Commissioner, for pulling this together. I know it's been a terribly busy week for you, and you and your team have really been astronomical in getting us all this information. Just to get an understanding, you have the numbers, but we were also looking for them by region so we could understand where they are and then where the open beds are.
So that's a different question that would be responsive to 5001. This is responsive to the governor's budget bill. So these were questions we took during the governor's budget presentation.
Yeah, I think I asked that during the subcommittee, and I was just trying to get that understanding because there was another question that I had asked also in the subcommittee as well.
So I will get back to you that there some we have sort of a scatter. Can I turn to one of my staff to help respond, Rep. Dathan, through you, Madam Chair?
Yeah, make sure that any information that comes forward goes through the committee administrator for all the members.
Yeah, Susan's one of our best friends. We get everything to Susan. Katie, would you mind?
Yeah.
Yes, absolutely. So we have been working on, we've provided some information by geography, by town, as far as where our CLA vacancies are. And then we were working on breaking down our waiting list by town. We have done that. And the response is just awaiting final approval, but we should be able to get that to you shortly.
That's great, because I didn't see that was going to be another question. So I will save myself from asking that and just thank you in advance for pulling that together and looking forward to getting this from Susan. Thank you so much, Commissioner, and thank you, Madam Chair.
Other questions of the Commissioner on this?
Before we move on from question 3, just clarification regarding an inquiry made during the time of this question around our dental clinic in Norwich. It's not our only dental clinic. It resumed operations with a hygienist starting in November, hygienists, that's plural, in November 2022. There was a delay through the fall hiring a lead dentist. They were hired in 2023 and they've begun scheduling resuming appointments now in March.
Mm-hmm.
The reason for the question is it had been taken offline due to a variety of issues that had come up, which have now all been addressed, and we can ensure proper health and safety for those receiving dental clinic supports there. And again, for anyone unfamiliar with our dental clinics, they serve both individuals in public and private, and can provide work and support and care that is hard to achieve in private dental practices for many of our individuals, whether it's body positioning, behavioral issues, any number of things, pre-sedate medication. And we continue to work with UConn Dental Clinic, St. Francis. We have a very good dental program for individuals with intellectual disability statewide, because oral health is health, and we try and take care of what we can.
Senator Austin?
Thank you very much. So, how far behind are they on appointments? Do you know?
I can't give you an exact number, Senator. I can tell you that there were some people who were delayed. We have a person dedicated to supporting the needs of dental issues at central office. They work for my director of clinical services and health and medical services. They worked with the hygienists and other staff to refer people and get other people appointments wherever they could. And the contractor we used for the prior dentist who vacated his role there or her role there was also willing to take and squeeze in a bunch of folks. But I am certain that there were people who didn't want to get introduced to a new dentist, who were only comfortable at the clinic. I'm certain there are a number of people who ended up with deferring their care, but I can't tell you an exact number.
Thank you.
Thank you, Senator. Other questions? No? ICF?
So the question was how many, and some of it's in data above, but we got the written questions. I think a lot of the questions, and some of them are questions, to be quite honest, between state agencies. But I want to go to question 4 and part B. What would it cost to extend the DDS settlement provisions to those ICF IID providers serving DDS consumers and funded by DSS? We're working through that calculation. There were some things when we did the initial look at it that were not making sense to the teams at DDS and others. And so we're trying to figure out what went wrong in that analysis and fine tune it. And we should have that shortly. It took a backseat with some of the other computations we had to do on wait list, but we'll have that for you very soon, I hope. There was a time, the comparison of needs between individuals in ICFs and CLAs. There was a time where there was a very much different level of care, but some of that difference has eroded over time. In that we have built capacity in our traditional group home models outside of the ICF program to provide both behavioral and medically acute care in CLAs. And given the way that we have traditionally placed people, both the regular group homes and the ICFs have been utilized for emergency situations. So in the written testimony that we provided, our LON scale, our level of need tool, goes from a 0 to an 8. And I think one would guess, based on the label and the history around ICF, that everyone living in ICFs would be at our highest level of need. But from what we know, there are some individuals with mid-range LONs. What we refer to mid-range is 4 through 6. And so in the assessments that we'll be doing, in looking both at the dollars and cents at the ICFs for that question, but also in terms of total bed capacity and how we might do things differently going forward with regards to 5001. We'll be trying to get a better handle on all of that. But there are some of the ICF facilities that absolutely do provide a very high acute level of care with a higher level of nursing than you would find in most privately run CLA group homes.
Senator Upton, did you have another question? Or
yes.
Okay. Sorry. Yeah.
Do you want me to ask it now, Madam Chair, or do you want me to wait?
If it's timely, ask it now, or we could keep going.
It's on ACFs.
Pardon me?
It's on the ICF.
Oh, well, why don't you ask the question now then?
Thank you. So, Commissioner, my understanding is that the people that work on the ICFs are being paid less than people that work at other group homes, but that the money is already in the budget to pay them if it would just be released by the agency, or allow them to spend the money that they have at the rate that would pay the people working at ICFs the same that other group homes are getting paid at. So that is my understanding. Have you looked at that situation to see what it would? I know you say you'll find out what it takes, but
Yeah.
This doesn't make any sense to me.
So the background on it is this: when DSS and DDS took different approaches as we administered cost of living adjustments, ours was a targeted wage increase, and while the language extended to ICFIDs, DSS used a standard percentage. And I think from the constituents you're hearing from, they're feeling that the rate increase DSS afforded them did not cover the minimum wage demand that the statute requires, and that is the shortfall. We were asked to consider helping make those providers who express that concern, make them whole, and we don't have a mechanism to pay them for those facilities as they're not under contract with us, and that is not yet resolved. I will tell you though, Commissioner Reeves at DSS and I, she's just getting on her feet there. Her background in the DDS provider world, I think, will be helpful in helping us come to a quick conclusion on some of these issues that are out there.
Well, I don't know. I've been talking about this issue for 2 years now. Every time I put something in the budget, it just doesn't get followed through to make sure that ICFs are paid the same as other group homes. And so I just am very frustrated by this, because I'm not certain what we have to do to make sure these people get paid. And nobody should be below minimum wage. It just should not.
Well, no, but not they're below the. So when I refer to the minimum wage, I refer to the 17.25. That's the minimum wage, not the state minimum wage. And Scott McWilliams is our CFO. He's working on this issue in partnership with DSS. Scott, do you have anything additional to add, or are we still just trying to resolve that analysis so we can try and fix it?
So yes, we're still working on the analysis to estimate the cost to expand the agreement, the agreement that was reached for DDS providers to the ICFs. However, I would say it's not accurate to say that the funding is in the budget of one of the state agencies to expand that agreement. We would have to calculate that amount out, and then it would need to be probably added into the budget for the Department of Social Services, because that's where those providers are paid out of.
Well, Scott, just so you know, in the talks that Representative Walker and I had at the table with the administration, we talked about ICFs, and we were assured then that the language that we had in the budget was going to pay the ICFs at the same level as everybody else, if not more, because of the work that they do. And now they're being paid less than the other workers. So that's my frustration. And this is not the first time. This will be the third budget cycle that we go into to correct ICFs. So I'm not certain what to do any longer, because it's apparent that this is something that is not, that people are not paying attention to. I don't know whether they are trying to get rid of ICFs, because we've had ICFs closed because they're not being paid. We have workers walking away because they can work at a regular group home, not an intermediate care facility. And I just find this to be very, very frustrating. I'm not certain which way to go with it any longer.
So I appreciate that, Senator. OPM is listening in. They're aware that it's a concern. And I know Commissioner Barton Reeves has heard the concern, as have I, and I will look to pull this together as quickly as I can, and clarify it all for you, and then try and rectify it as best we can.
Okay, I don't need anybody to clarify it for me. I just need people to tell me what we have to do to put in the budget to get people paid.
Okay.
Because I already understand the issue of ICFs. I just have asked, this is again the third budget cycle that I have been assured that this issue would be dealt with. Assured, sitting at the table with the administration, of course you're not there, but sitting at the table and still can't get these people paid. And we asked, both Representative Walker and I asked, when that contract negotiation came out, we wanted to make sure that all workers in DDS and DMIS were getting the same benefits, and we were told yes. That across the board, we were told yes. And And it's very, very frustrating to find out that we have workers in the same agency and doing similar work that is just being paid less than other workers. So thank you, Madam Chair.
Understood and noted. Thank you. Anything else on ICFs before we move on?
No, I think we should move on. I don't see another hand. And I'm remembering now that I read this very early this morning. It's very, it seems to have been a longer day than I expected, but go ahead.
So just briefly on number 5, youth involved in juvenile justice. We work closely with DCF, the probate courts, the Court Support Services Division, to identify and to support DDS eligible individuals as appropriate. There's some pretty active care management in there that reaches out to us if they have any inclination that someone may be eligible, and then we assist them in making the application process if they're not already eligible and known to us. So that's the answer to number 5.
I think there's going to be a lot more interest in the eligibility and in whether or not, I know there is, and whether or not we're currently correctly identifying people who should be in their services, and whether the department is reaching out to enough communities. And I've been hearing that for a long time, but I'm hearing it a lot now. So that's a historic issue, but one that I think we're going to have to be respectful about. Are there any questions about number 5 from the committee? No?
I have a question. I'm sorry, I'm off screen.
And
Yeah,
there you are.
If I may, yes, I just have a question in reading that. It says, and hi, Commissioner, the documentation of both deficits before the age of 18. But what happens if they were in a situation where they weren't identified, but you can clearly tell that this person is in need of support? Would they not be eligible?
So DDS doesn't tell people that they're not in need of support. We just say that they don't meet the statutory definition as provided by the legislature for eligibility. So we often refer individuals to other places. If they are not eligible for DDS, they may get other services through other state agencies, including DEMIS, Aging and Disability Services, and DSS. There are situations where individuals come to us and there's no evidence of the lack of the lower IQ or any testing done during that period. We do try and work with those families to establish some. So, for instance, people who come from out of state who can't access their primary school records is a situation, or someone who never applied for services, whose parent passes away, and we don't know anything about them. So there are other ways to assess that. In the standard, the IQ is one part of that. It is a frustration for individuals whose cognitive impairment isn't identified prior to the developmental period, but that is the way the statute's currently written.
Okay. Thank you so much. Thank you, Madam Chair.
You're welcome.
Thank you, Representative. I'm always going to be skeptical about this. So, you people who don't fill out forms. We have people who, depending on what town they live in, don't apply for school lunch because they're afraid of filling out a form. Maybe a parent with a literacy issue. Mm-hmm. A lot of people are concerned about whether we're reaching everybody now. And I'm not saying that to make any accusation towards any individual but that's a concern, and it's getting more visibility. So anyway, I said my piece. Thank you very much, Representative. I think we agree. Any other questions on number 5, number 6?
Number 6 is with regards to our wait list. And DDS maintains a waiting list for residential supports. some individuals on this list are currently not receiving any annualized residential supports. They would be in the column marked as not receiving services. Some individuals receive some annualized residential support, but not all the support that they currently need. Candidly, we are struggling to get some of those supports in place due to the workforce crisis. Those numbers would be lower if agencies had more workers. So we have some capacity in the system, and it is not a lack of interest on behalf of our providers. Our providers would just as soon everyone who needs supports and got it through them and as soon as they could. They're just not able during this time to ramp up to do that. But those are the numbers with and I think I mentioned during my testimony yesterday in Human Services that with the category CCH or community companion homes, we have green lighted our allocation teams that anybody who asks for placement there, we will work to identify a placement. That is less of a staff issue right now and more of just trying to match people with the right homes. But the individuals not receiving those services, that's not a funding issue for us. That's just identifying the right home for them. And likewise, we have some money within our appropriation to address some of those other needs. And we're just working with providers to ramp up their staffing so that we can take some of those people off the wait list. It won't drop the number dramatically, but there is some capacity if we can find the workers for them.
Questions? No. Exemptions for military families?
So I said during my testimony that we have made eligible and paid state dollars. I can't find my paper trail on that. But I remember a call asking me to see if there was something we could do for one of our for someone serving now in Connecticut, having been transferred, I think from Hawaii or California. And I think we made that accommodation. But we don't have any formal policy. What we do is we look at the needs of every individual one at a time. If they're living here and they are eligible and they need supports, we try and do that. And so that's the response to exemptions.
So we have a scarcity issue with clinicians and we have a scarcity issue with housing. Yep.
There's a scarcity of everything. Yes. There are not enough peoples.
Okay. Okay, thank you. Number 7, and other question. Oh, I'm sorry, Representative Echo. No, I love it. I love your questions.
I really just wanted to make a comment on the military family side, because we experienced that here in West Hartford from a family in Colorado that transferred here, and through military means, no wait list, getting services, and then they were told that they couldn't move up. So it sounds as though there was some connection made there. I hope that's maybe the family and it comes to mind, because it seemed very unfair that they would not be able to get, they moved here because of no fault of their own for doing work, for being a part of the military. So I'm happy to hear there is some type of exception around that. So that's more of a comment.
Thank you.
Thank you.
Commissioner, did you say you didn't have the paper with you though?
I looked through my email for it, but I have a lot of email and I was trying to search for it by the state because it was out of state, because just looking for the word emergency or the word military in my email will bring up, 30,000 emails. So, so I'm trying to find it because we had an inquiry and I said we would try and be responsive, and I don't know where it left off. So I'll continue to look in my spare time to see if I can find that one exception. I don't think it was West Hartford. I think it was down at the Naval Shipyard, down in the southeast corner of the state. So that's what my recollection is, but it could definitely be wrong.
Okay, I'll be connecting back, because they've reached out, and there was a family that moved here from Colorado because of the military. So
and Representative Exum, if you have the name and you can give that to me, that will make my search so much easier.
Okay, Okay, I'll look for it and I'll get that to you.
Thank you.
And Commissioner, I wanted to just add, and it doesn't really fit quite here, that I'm looking at my text messages, which is also always a dangerous thing on a Friday afternoon, that I had forgotten to ask about Spanish-speaking clientele. And so I just wanted to park that there in terms of what kinds of outreach and whether that's one of the populations that get served. And we don't need to discuss it. I was being reminded that I forgot to ask.
So I'll just give you a 30-second blurb. We fund through a grant, Connecticut Family Support Network, CTFSN. They hold a parents Spanish-speaking group in particular and are looking for more people from that community to become involved. They have tremendous staff. They've been on each of our stakeholder calls that we've had. And we can connect any constituent concerns for people who are Spanish speaking through that network. And I think that can help them get up to speed.
Okay, thank you very much. Representative Dathan.
Thank you very much, Madam Chair. And just to reiterate, Commissioner, I'm sure you heard yesterday, there was another family that lives in the Groton area that are part of the Coast Guard, moved from California, and they still don't have the services too. So I really wasn't kind of aware that this was a major issue until we talked about it in committee. I guess it was last Friday. And then hearing it yesterday in the public hearing. So I just emailed my intern to double check where that person's details are so we can look into that specific case.
Thank you. But if we can get I don't want to get into her personal details today.
Sure, no.
But we'll be happy to follow up with you offline.
Yeah, absolutely. And the same thing, Tammy and I will coordinate on her issue as well, because I think this crosses over to 5001. Thanks.
Great, the behavioral services question.
There was a question about why funding is being reduced. Our answer is multifaceted. One, the stand up of the state plan amendment that allows people under 21 to get services through Beacon, through the EPSDT or other state plan amendments, has reduced the demand on those cases. And our numbers in that have dwindled as a result. We also have really in alignment with the philosophy promoted by Commissioner Durantis, have really tried to keep children intact in their family and provide supports there, as opposed to out-of-home placement. And as you can imagine, those supports are less expensive when we're supporting an individual in the home. And those are the reasons for the reduction in the funding there. Okay. We don't have a wait list, and we haven't told people no.
Okay.
It has not been a reduction of service.
Number 8, definition of disability.
We spent a lot of time on that yesterday in 5001. I think we have a lot of work to do. I think this speaks for itself, and you know the history of using the IQ score and developmental period in that language. Yeah. I don't know that we need to use a lot of time today going through it further and just continue to work on that discussion through session.
Okay. Number 9.
Katie, do you have anyone queued up to sort of walk through this, or do you want me to do it?
I think probably Krista, our waiver director, is best positioned to just run through. And I know we've provided these updates in a few forums. I'm sure you've all heard them, but Krista, if you're
I didn't see she was on. That's terrific if Krista's here.
Good afternoon, everyone. My name is Krista Ostaszewski. I can quickly run through the ARPA HCBS reinvestment provisions, and then we're happy to provide any additional detail or additional summaries that may be necessary. There's a lot of work being done on each of these different components. There's a lot of details associated with it. So I think what we attempted to do is really capture the highlights and make sure to provide you with a general summary, but again, always happy to provide additional information. So a few of the different provisions that are funded through HCBS ARPA, and really because the ARPA term is being used so often, what we're focusing on here is the HCBS ARPA, which was specific to enhancing and improving home and community-based services funded through Medicaid. So a little bit earlier, we talked about the ARPA funding that's really state-funded ARPA. That's separate and distinct from this process. So the first provision that is funded through ARPA HCBS is the Workforce Stability and Development process. So we are providing some funding for provider communities to create incentive-based programs for recruitment and retention. Obviously, we've talked about very often the workforce challenges that were already out there and that the pandemic then unfortunately made worse. So we are working through payments for DDS providers to really focus on developing staff, recruiting and retaining staff, and stabilizing the provider workforce. Representative, would it be helpful if I stop after each provision to see if there's questions?
No, we'll see if somebody puts their hand up. I mean, I think what this section is important. Certainly, one thing that really was very, very painful during the pandemic was the way that we did access to vaccines was by age. But someone, particularly if you have Down syndrome, had a higher risk for hospitalization and maybe even death based on the literature out of England. But if you were placed in the community, you didn't fall within Connecticut's arbitrary, I believe, the guidelines. That is that you had to be in a congregate setting to be considered at risk. And that created a lot of distress here because we have a lot of people who live in the community. I would really like to think going forward at all of these things, which I think are very positive that you're looking at, and realize that there are some lessons that we should have learned from the pandemic, and I don't know, and that we need to act on going forward.
Yeah, absolutely, Representative. I think that's something that we worked very closely with DPH on, and sort of made sure to offer the individuals that we support some separate and distinct options for becoming vaccinated. I don't know if staff want to talk through that. I think it is a little bit separate from the ARPA HCBS reinvestment options.
Well, I just want to, having had some pretty painful conversations at a higher level, it was very difficult to get it. You know, there was kind of a narrow, well, no, they're not in congregate, they're not at risk. I was like, well, if you're isolated and you're living in your apartment and you can't go to class because it's a risk for you, it sets you back, you know. And so I'm much more vigilant about some of these components now, because that was a very, very difficult time.
Thank you, Representative. Is Representative Dathan's hand up? Should we?
Yes, just very quickly, while we're talking about these ARPA items, I'm wondering if you can break it out so we understand how much funding the providers have gotten for workforce stabilization. I know in speaking to different providers, one of the challenges that they face is that they're not able to train and do other things to create that sort of workforce sort of stabilization and also retention. Just I want to get an understanding how much that has gone and if we have any sort of metrics on the ROI of programs like this.
Yeah, that's no problem. We can provide
for today. So
okay.
Yeah, I need it by 5 o'clock. So
we have that information, and what I will say, Representative Dathan, is we've provided some of these payments already, and do have a schedule of sorts for some future and additional payments as well. So we can work with the team to provide you with that information.
Thank you, Madam Chair.
Absolutely. Representative Dillon, I'm going to move to the second bullet, if that's okay.
No, that's fine. I was really looking at the whole list here rather than focusing on the first anyway. And
not a problem.
Yeah,
so
thank you.
No problem. So the next provision that we are working through is really improving, enhancing, and expanding on access to assistive technology. So we're doing a few different initiatives to make sure assistive technology is something that families and individuals understand, have access to, and also have the ability to utilize the supports in a way that allows them to become more independent, but also do it in a way that complements additional supports and additional staffing supports that they're receiving. So I won't go through all of the different initiatives, but there's a few different pieces going on to really increase and expand the utilization of assistive technology, but also make sure that we're educating families and individuals about what assistive technology is and what's out there and available for everyone.
Any questions? Nope. Okay.
Okay. We are enhancing self-direction to focus on improving and enhancing the workforce recruitment and platforms for such recruitment. So part of the a specific program that we provide through DDS is self-direction. So it essentially allows individuals to self-direct their own supports. They're able to hire their own staff. They're able to oversee their budget and determine how they want their supports and services provided. One of the things that we continue to hear from individuals that self-direct their supports is that they want another method for recruiting workforce, right? So we have, for DDS, we call them DSPs, direct support professionals, but I think they're also referenced as PCAs. So essentially the process that we're looking at here is to create a platform where we can really offer the ability for DSPs to post their credentials, and for families who are looking to self-direct to go to this platform and decide if there's employees there that may fit their needs. So again, really sharing information and making sure that those connections are there. The other piece of this that's really exciting is that we're hoping this platform will also assist with providing emergency backup staff. So what happens for the individuals that self-direct their supports, if a direct support professional calls out last minute, there isn't another staff person that's immediately available. So part of what we're looking at is a system to make sure that there are direct support professionals that can step in last minute. It's a need that families have articulated to us, and we wanted to make sure to explore that as part of this process. So the next, I'm sorry.
Go ahead.
Okay, thank you. So the next initiative is we're looking at doing some system upgrades for a few different systems that are utilized at the department. The first is our case management system, really looking at a more modernized case management system to streamline supports and services for our individuals and make sure that our case management system talks to other systems as well. So we're excited about that process. As we know, it is a detailed and complex process. So we're starting with researching and working with CMS to look at different funding options as well. We are also looking to improve our incident management system. So we currently have an incident management system that uses Medicaid claims to determine if a critical incident has occurred. We're looking to now input Medicare data, level of need data, and admissions and discharges into that system, just so we can have a more holistic approach to looking at if a critical incident has occurred. And then obviously looking to improve our billing processes efficiencies for our providers. So the system upgrades initiative is pretty expansive in terms of what we're looking to do there.
Mhm.
I'll keep moving on. The next initiative we're looking at is expanding supportive housing models. We've talked a little bit about supportive housing in a few different public hearings, but really it is a model that we're hoping to replicate. We know individuals want the ability to live independently, and really being able to partner with some of our sister agencies to put some more supportive housing models on the map is something that we really would like to focus on. So we're working on a few different initiatives to expand supportive housing models and really make sure that supportive housing is a process where the model itself is integrated into the community and it promotes the highest level of independence for individuals that we support. So we're excited about that work. We have some really good models that have been incredibly successful to sort of base our work off of. I think the commissioner spoke about some of them yesterday at the Human Services public hearing. So we're excited to continue to work through that. Okay, so the next piece is about strengthening. Oh, I'm sorry.
Just
Representative Dathan has a question.
Just very
Representative, would you like to ask it?
Yes, very quickly. I'm so sorry, Madam Chair. The supportive housing models, can you, I don't have my ARPA sheet in front of me. What is the total amount of ARPA funds going to that? And is it planning on all going out in fiscal year 24 or 25?
Representative, I unfortunately don't have that information in front of me. I'll see if perhaps our CFO, Scott McWilliams, does. And if he does not, would it be okay to provide that afterwards?
Krista, that's fine. Next week is fine. Thank you so much. Thank you, Madam Chair. Thank you, Krista.
Absolutely.
Yeah, it was this one that I was thinking of with the vaccines, but obviously it has implications. We had a bill in environment last year based on an EO of the governor's that allowed you to get use a proxy for certain kinds of food assistance. And I'm still looking at some of this through the lens of the pandemic because it was so dramatic, but go ahead. Thanks.
Absolutely. Thank you. I'm sorry. I think, Kevin, are you sharing? Oh, thank you. Just going to ask that you scroll down. So we are focusing some of our initiatives on strengthening the quality of supports and services that we provide, right? Not only do we want to provide, expand, and enhance supports, but we want to make sure that the quality of our supports are at the highest level. So we talked a little bit about our critical incident management system already. It is named Pulse Light, so that's what you see there. But a few other initiatives that we're working on to strengthen quality is, as part of our Medicaid waivers, we are required to gather feedback from individuals about the supports and services that we're providing. So we actually implement a survey called the National Core Indicator Survey. It's a pretty lengthy survey. We pull a pretty large sample, and we go out and conduct a survey directly with individuals to determine if their supports and services are meeting their needs. And we get that feedback directly from the individual. In the past, that survey was something that was done through DDS specifically. So DDS staff were the ones that went out and did the survey. It was always a challenge because the survey was, it is lengthy. It's usually done in person. There is a remote option, but many families prefer to do the survey in person. And it was something that staff had to do on top of their regular work and responsibilities. So what we decided is to actually contract out to a third party to implement the survey itself. And we're really excited about this process. We've already started to work with the third party to implement the survey. They've actually gotten a pretty good amount of surveys already completed. And one of the things that we're hearing and that we're going to look at is how does a non-DDS staff person conducting a survey influence the survey results, right? So prior, we had DDS staff asking, how do you like your DDS supports? Now it's going to be a third party saying, how do you like your DDS supports and services, right? What can DDS improve on? What is DDS doing well? So we're going to look at how that influences the responses. And then the third party is also going to do some pretty intricate data analysis on those feedback surveys as well. So we're excited about that initiative and we're looking forward to the results.
Great.
So the last piece is around system transformation. And I know this has been something that we've talked about in numerous different public hearings because it is directly connected to a lot of the work being done on the wait list. But essentially, the last initiative here, we're really focusing on transforming the DDS system. We're putting together a comprehensive plan to move away from congregate settings, both in residential and day, and toward more integrated settings that promote independence and freedom of choice. So we have numerous different incentives and processes that we're working with providers on to work with them to start putting together a plan on the future of supports and services, right? So right now, if a provider is providing a congregate day support, they can be incentivized through numerous different means to put together a plan to move toward more independent and employment-based services and supports. The conversation is holistic. The families need to be a part of those conversations, as does the individuals. And we're going to be working with them in very close proximity to get them to a place where we're focusing on providing more integrated supports in the future. So, Commissioner, I know this is something you've talked about often every time we've talked about HCBS, because this really, I think, is like our spearheaded initiative. So I don't know if you wanted to go into more detail on that.
And I did want to say to the committee members, I know that we have now gone over our time since we were set to end at 4, but we only have 2 more questions after this. So go ahead. Sorry.
Yeah, that's okay. I'll be brief. I think I can help expedite some of the questions and be responsive to Representative Nuccio's questions as well. So first of all, thank you, Krista, for teeing that up. When we were conceiving of how to spend the ARPA money, we collectively wanted to see if we could use some of it to chip away at the wait list, as a lot of the funding over the last couple of years has very necessarily gone to fund direct care staff. We were trying to see if we could broaden our continuum of supports and services and create some efficiencies and try and create some movement that would allow some people to come off the wait list. I have to be honest, as Representative Case said to me yesterday, in one fashion or another, this is going to happen. And that I think that the work we've already begun here pairs well with the speaker's bill, at least in spirit, and we'll just work with you on the money part. In terms of the rest of the testimony, Representative Dillon, question 10 is around the issue of funding to providers in the budget. While the governor provided caseload growth and other money in the budget, we were confident that some of the ARPA money we'll be putting out the door will be helpful in stabilizing the providers, and we can provide some more detail as we finish the process for application therein. I'm not going to read you on Friday afternoon at 4:05 a bunch of numbers about our vacancies, but there they are in print. We're happy.
I want to make sure, right? Okay, yeah.
Go ahead.
I want to. If Representative Nuccio is still with us, I want to make sure that we're respectful of.
I am, ma'am. I am.
And so with regards to Representative Nuccio, we have another sheet for as did Demas, and I'm not sure why, but happy to be spotlighting. Before you ask the question, I will tell you, no, we didn't provide some of the data that you were looking for. We also referenced the comptroller's letter. So we'll work on getting you the specific numbers in the lapses and the other questions that you asked my colleague at Demas to make sure that you don't have to dig through the 100 pages.
I so appreciate that.
and we will work on that. It won't be this weekend. Staff need a little time. And then we have, if you wouldn't mind though, I think the rest of our responses to your questions are pretty specific, and a lot of them are numbers, and I'm really uncomfortable just reading legislators who can read quite well themselves lists of numbers. I'd be happy if you wanted to take a look at that and had any follow-up. I'm certain that we can facilitate a one-off phone call, or any of your colleagues who'd like to join as well to go through any other specifics, but I think we've otherwise fully addressed your questions outside of the lapsing.
Well, I do want to make sure that all the committee members have access to the same information. And I know that there are competing demands. Some people may even not be, they may even be taking personal time now, but and I know, you know, for example, with us, we had a public hearing yesterday, and none of us, many of us had nothing to do with the Human Services hearing, but I want to make sure that that when it comes to your responses and the other commissioners' responses, that everyone on the subcommittee has access to the same information, and you can understand that.
Yes, absolutely. We'll ensure anything that we communicate where it isn't the full group gets communicated as well to Ms. Keene to make sure it's disseminated to the whole committee. My promise.
Okay, and Representative Nuccio, how would you like to proceed in terms of the issues laid out by the commissioner?
I'm fine with them sending me the detail for the lapses. They send it to Sue. Sue can send it out to everybody. So I'm fine with that. And the information they provided on their vacancies was good.
Okay.
Thank you very much.
Okay, great. Thank you. Any further questions? No? Okay.
If Ms. Keene is still listening, you can schedule me the last booking every Friday afternoon in future sessions. That'd be great.
You betcha. This is your slot permanently, Commissioner Chef.
Thank you, Susan.
Representative Exum.
I'm sorry I'm off screen, but I just have a quick question. When we were talking earlier about Southbury and asking for that demographic information, and I know, isn't there a way to get it? I mean, we're not asking for the names and the specifics, but can it be redacted so we can at least get a little bit more?
There's a lot of information we can provide you. Some of those individuals moved into Southbury long ahead of us identifying people by race in our electronic system. One of my staff, he's in charge of our business intelligence unit. Josh, are you available to come on? Do you think we have data that would be comprehensive on race and ethnicity at Southbury?
I think we can provide what we have. Absolutely. And I should say, for everyone's benefit, the Public Act 2135 requires state agencies, health and human service agencies, to collect race, ethnicity, and language data in a standardized format. And that is being implemented over this next year. The categories will be standardized, which will allow for much better analysis and reporting of equity, as many of us wish to do. And we will work to get you the information that you're requested in a way that's allowable as soon as possible.
Fantastic. Thank you so much.
Thanks, Josh.
Thank you.
Thank you so much, Madam Chair. Last question. That was it.
No, thank you. And there's been a lot of questions coming in from outside of appropriations from some of our other members who are so that there's a lot of interest in that. I don't think people have thought about Southbury for a long time, and the moratorium on admission to Southbury was put into a budget at the request of a Republican senator who had been one of the litigants in the closing of Manchester Training School, and so that I think that the expectation was that would have an effect, which it has not had. But it was certainly something that a lot of people wanted in terms of more humane placements. So we've come a long way in terms of the way that that's looked at. And I haven't really looked at Southbury for a long time, so the questions are interesting, and it's good to take a look.
Terrific.
Any other questions? Nope. Thank you.
Have a great weekend, everyone. Thank you.
You too.
Thank you, Commissioner. Thank you, Madam Chair.
And thank you, everybody. We'll have a chance to get together again.
Thank you,
Thank
Madam
you.
Administrator.
Thank you.